Module 18, Disordered Eating and Eating Disorders. What's the difference between disordered eating and eating disorders? Well, disordered eating describes a gamut of abnormal and harmful eating behaviors that are used to reduce body mass or maintain body mass below normal body fat levels. So an eating disorder is going to describe one of the three clinically diagnosable conditions, and we'll look at what exactly comprises the clinical diagnosis for these. So these two terms are not synonymous. What's the Diagnostic and Statistical Manual of Mental Disorders for? Well, this is a disorders manual published by the American Psychiatric Association, and it was first published in 1994, but more recently the DSM-5 actually came out in 2013. And with respect to eating disorders, very little changed, and I'll highlight some of those changes as we go through these slides. So let's first look at anorexia nervosa. What are the diagnostic criteria to say that someone has anorexia nervosa? The first thing that you have to consider is that all of these criteria that you see here, criteria A, B, C, D, are all criteria that have to be present in order to confirm a clinical diagnosis. That's how this manual works. So under criteria A, what has changed is the word refusal. So this now has been eliminated from the rhetoric in this manual, and you could replace that with failure to maintain body mass within a minimal normal weight range for age and height. So we expect to see that the body mass is below 15% of where it's supposed to be. There's a failure to gain body mass during periods of growth, so that body mass is less than 15% of expected. So that's the first part of diagnosing someone with anorexia nervosa. You have to have that present. The second criteria B here, we have to have an intense fear of gaining weight or becoming fat even though the person is underweight. So that has to be present as well. In criteria C, there has to be a disturbance in the way in which one's body mass, size, or shape is experienced. There must be undue influence of body mass or shape on self-evaluation, and there must be a denial of the seriousness of the current low body mass. So that is also a criteria that has to be present. In criteria D, we have post-menarcheal females, amenorrhea. This is something that has changed, where the absence of at least 3 consecutive menstrual cycles, that now has been eliminated from the rhetoric in the DSM-5 manual, because some females do report some kind of menstrual activity, although it is probably not regular. So criteria A, B, C, and D have to be present in order to make a clinical diagnosis for anorexia nervosa. The types of anorexic nervosics include 2. The primary one that you'll see is the restricting type. That's the primary type of anorexia nervosa. Most of anorexic nervosics do use this as a means of regulating their body mass. But we also have the binge eating / purging type. So there are some that binge eat and then expunge those calories somehow by purging them through various means. That is a secondary type, and that is only going to happen exclusively during an episode of anorexia nervosa. So you may be thinking, well, wouldn't it be classified as binge eating disorder or bulimia nervosa? No, it has to have has to happen only during episodes of anorexia nervosa. So all the criteria A through D must be present, and then this is just the type of anorexic nervosic that they are. So it's really distinguished by the regular use of this during episodes of anorexia nervosa. The prevalence of anorexia nervosa is quite disturbing. It usually involves death by starvation, suicide, or some sort of electrolyte imbalance. Usually it occurs during adolescence and early adulthood, and it's more prevalent in females than in males, although it does affect about 1 in 10 males. About 0.5% to 1% of all cases do meet the full criteria, and unfortunately, there is a 10 to 18% mortality rate in this patient population. So now we'll move on to diagnostic criteria for bulimia nervosa, and actually very little has changed in the DSM-5 with respect to bulimia nervosa. In criteria A, we have recurrent episodes of binge eating. So this is eating in a very discrete amount of time, like a 2-hour time window, an amount of food that is significantly larger than most people would eat during a similar amount of time and under normal circumstances. There's also a sense of lack of control when the individual is overeating during this episode. So this criteria has to be present. We also have to have criteria B present, where we have recurrent, inappropriate, compensatory behavior in order to prevent body mass gain. So in other words, there has to be some sort of expunging of those calories. We have to purge ourselves of the calories. So how is this done? Well, we have self-induced emesis or vomiting. Laxatives are sometimes used, diuretics are used, enemas are used, medications, fasting, and excessive exercise into the hours through a day. So for example, someone may exercise 6 or 8 hours just to purge themselves of those calories that they just consumed. In criteria C, the binge eating and inappropriate compensatory behavior is occurring, both of which are occurring on average at least, and this is what's changed with bulimia nervosa, and that is it's occurring at least once per week for 3 months consecutively. So that criteria has to be present as well. Criteria D, we have self-evaluation is unduly influenced by body shape and body mass. That has to be present. Criteria E, the disturbance does not occur exclusively during episodes of anorexia nervosa. So they cannot be diagnosed with anorexia nervosa. They have to be diagnosed with bulimia nervosa and have these disturbances only occur during the bulimic nervosic episodes. That would be the distinguishing factor. As far as the types here, we have the purging type that uses emesis, laxatives, diuretics, enemas, etc. And then there's the non-purging type where basically fasting or excessive exercise is used to eliminate those calories that they ingested. The prevalence of this usually occurs in adolescence and early adulthood. And again, just as we saw previously, it's more prevalent in females than in males, although again, 1 in 10 males are suffering from this as well. About 1 to 3% of cases actually meet the full criteria, and they're predominantly of Caucasian ethnicity. Now, if the individual does not fall into the criteria of either anorexia nervosa or bulimia nervosa, then they are classified with EDNOS, which just stands for eating disorder not otherwise specified. And so there are criteria again here for these individuals to be considered with EDNOS. So criteria A, we have for females, all the criteria for anorexia nervosa are met except that the individual is eumenorrheic, so they have a normal menstrual cycle. They also have to fall under criteria B, where all of the criteria for anorexia nervosa are met except that, despite significant body mass loss, the individual's current body mass is in the normal range. So they have a normal menstrual cycle, their body mass is within the normal range. They also have to have criteria C. All of the criteria for bulimia nervosa are met except that the binge eating and the inappropriate compensatory mechanisms are occurring at a frequency of less than twice a week or less for less than 3 months. In criteria D, the regular use of inappropriate compensatory behavior by an individual of normal body mass after eating small amounts of food, that also has to be something that they are diagnosed with. Criteria E, they're repeatedly chewing and spitting out but not swallowing large amounts of food. That's another behavior that has to be present. And criteria F, they have binge eating disorder, reoccurrent episodes of binge eating in the absence of regular use of inappropriate compensatory behaviors characteristic of bulimia nervosa. So they're not compensating here, they're just engaging in the binge eating part of that behavior. Some special notes about eating disorders is that they rarely occur before puberty. With precocious eating disorders, so eating disorders that occur before puberty compared to adolescence, so within the 13 to 18-year-old category, the mental disturbances may actually be greater and the prognosis can be actually poor, so it becomes more difficult to treat an eating disorder if it's happening before the age of 13. In athletes, it is interesting that the eating disorder may actually disappear and never appear again once the sport is discontinued. So there may be some sort of stress or pressure that's present that causes the athlete to trigger for an eating disorder. We know that there are some gender differences of those that do have a clinical eating disorder. They've been diagnosed. About 90% of them are women. Some words spoken by a successful female athlete, cross-country runner, recovering from anorexia nervosa, which is kind of interesting and gives you some insight into this disease. For women, eating disorders are like steroids for men. You'll get results, but you'll pay for it. So that's kind of an interesting statement to take a look back at and reflect on with respect to eating disorders. There is less research conducted in males, simply because it is much more prevalent in women, and also just overall in athletes. There are far fewer studies that look at athletes and eating disorders. What is muscle dysmorphia? This is what we refer to as the Adonis complex, and it is a preoccupation with not being sufficiently lean and muscular. In the eyes of the person that has muscle dysmorphia, their ideal man, which most of these individuals do tend to be men, they have 28 pounds more of muscle. So they're striving to have about 30 pounds more of muscle than they already have, even though they may be very muscular and lean to begin with. There are many similarities with anorexia nervosa, and their physical appearance, as I mentioned, usually is very large and muscular. So the signs and symptoms of the Adonis complex. We have a preoccupation with being lean and muscular. So this involves frequent weighing, a little bit of narcissism where they're constantly checking themselves out in mirrors. There's a persistent criticism of physical dimensions, so they may not like the size of their biceps, for example, so they're always criticizing that particular area. They can wear baggy clothing to try and cover up any perceived imperfections that they might have. Some of them even modify the clothing to enhance their muscularity. The sad part about this is that there is clinically significant distress or impairment of things like social interaction with other humans, occupational problems, relational problems, familial problems. So it does affect the person's life as far as how they interact with everyone else, their work, that can be affected. So their whole life is affected by this because they are just overcome with this perceived imperfection that they have. They also may engage in very excessive exercise to correct any perceived differences. They may tend to abuse dietary supplements. They may have a very strict adherence to some very specific dietary regimen. As far as their psychological profile is concerned, they may view themselves as frail and small, although they are quite large, muscular, and quite strong. They'll spend greater than 3 hours at every single day thinking about their muscularity. So you can see how this just overpowers a person's life, that they're spending so much time thinking about this, that they're not engaging in other activities throughout the day. So it can be very all-encompassing and overwhelming for these folks. What is a subclinical eating disorder? Well, this is when athletes or even non-athletes who present with significant eating pathologies and a body mass concern, but they fail to meet all of the DSM-4 or 5 criteria and or significant psychopathology. So they can't be clinically diagnosed with anorexia nervosa or bulimia nervosa or edenos. So they are at a subclinical stage. So they're not clinically presenting with any of those disorders. So as an example here, you might have an athlete that uses laxatives to control their body mass, but they're not classified to any of the DSM criteria. What is disordered eating? Well, disordered eating is a subclinical eating disorder. So this is where the person may have distorted concerns regarding their body mass, their fatness, or even their shape. Their behaviors and practices aren't what we considered normal behavior and certainly not conducive to good health, but they fail to meet the very strict criteria that the DSM-4 and 5 have outlined. So their psychopathological profiles generally are not present in these individuals. So it's a subclinical disorder. It's a what we considered disordered eating. As far as athletes and disordered eating are concerned, the prevalence of this in women, about 1 to 62%. It's all over the place. Men, 0 to 57%. And the differences really come down to the screening tools that are used. There really is no standard set of tools that are used to screen athletes, and a lot of them haven't been tested in athletes. The definition of the disorder and, of course, the athletic population study, these are all reasons why in the literature you're going to see just a huge variance in the prevalence of disordered eating. They may sometimes exhibit psychological traits that are associated with clinical disorders. They have a high achievement orientation. I think that goes without saying. If you're competitive and you want to excel in your sport, there has to be some sort of high achievement present that they're striving for. There are obsessive compulsive tendencies. There's a sense of perfectionism that's necessary in competition. So these traits are often associated with athletic performance. And perhaps they are very necessary, but sometimes they can lend themselves to things like disordered eating and, in extreme cases, eating disorder. So disordered eating might actually be more common in this particular population just because of the given nature of sports, particularly females and aesthetic sports where a low body fat seems to be the goal or standard that that particular sport demands or expects. There has been some proposal of another class of disorder called anorexia athletica, which would be a subclinical characterized by a disordered eating classification. So it wouldn't be a clinical disorder, but it would be subclinical, but just to categorize it specifically for athletes. This is where there would be an intense fear of gaining weight or becoming fat, even if the individual is 5% less than expected body mass here. Their body mass loss is achieved through energy restriction and or extensive compulsive exercise, and some athletes may report the use of binging or self-induced emesis, laxatives, or diuretics. So this hasn't been well defined, and it's not certainly part of the DSM manual just yet. So there needs to be more work done in this area before we can actually use the term anorexia athletica to describe this particular population. Who's at risk for disordered eating and eating disorders? Well, any athlete that's participating in a sport where aesthetics is highly valued or viewed, that certainly would put them at risk. If there's a perceived physical or biomechanical advantage of a low body mass and low body fat, then the prevalence could be higher. If there's a weight category sport like wrestling or the horse jockeys, that could increase the risk for an eating disorder or disordered eating. If there are social cultural factors like the media and the potential for, if I'm an athlete that's really successful and I want to get that advertising contract so I can make more money, there's certainly that as an influence as well. There are psychosocial factors, so individuals with eating disorders who typically come from dysfunctional families. Maybe they come from an overbearing or controlling parental influence. Perhaps they're victims of physical or sexual abuse. Perhaps parents with alcoholism or some other sort of substance abuse, that kind of environment, that could be a psychosocial factor that affects the individual and predispose them to an eating disorder or disordered eating. Then there are biological factors. Some folks may just be at increased risk for anorexia and bulimia nervosa. There is a familial inheritance, so first-degree biological relatives with these disorders tend to predispose their kin to a higher risk for eating disorders or disordered eating. We know that it can be higher in identical twins compared with fraternal twins, which is kind of interesting. And then gender does have an influence as well, 10 to 1, as far as females versus males and the prevalence of that. The early onset of menarche could actually be a biological factor that triggers this, because some have the mindset that menstruation shouldn't start, at a given point in life. It should start later, or for that given particular sport. So that's an issue that we want to look at biologically. They may have a propensity towards obesity as well. What about psychological and behavioral factors? Do they contribute? Well, we do know that personality traits contribute significantly to a predilection for disordered eating and eating disorders. Athletes in particular do exhibit some traits that we often find in patients who have eating disorders. They tend to be goal-oriented, achievement-driven, they're independent, and they're persistent. Athletes are very tolerant of pain or discomfort. There is a pursuit of thinness that is similar between sedentary and exercising individuals. Exercisers do display some anorexic/bulimic eating attitudes, as well as a greater drive for thinness. However, athletes don't quite have the full behavioral and psychological profiles that we see in eating disorders. So there is a little bit of a difference there. Athletes do tend to be striving for perfection, which is in line with being very, very competitive and striving for first place and winning a race or competition. There are feelings of personal ineffectiveness that may be present, or guilt, or even distrust. There are some obsessive personality traits that may manifest as well. Additional psychological and behavioral factors include high achievement expectations. For bulimic or nervosics, that may include impulsiveness, intolerance to hunger, psychological distress, and narcissism. For anorexic nervosics, that may mean sensitivity, obsessiveness, being a perfectionist, and avoidance, particularly of social situations that involve food. Exercise participation is also another factor that we want to consider here, particularly if the person is part of a sports team that is training more than 3 times per week. And if you take a look at some data that's out in the literature using some of the screening tools that are available, there are 2 tests that are listed here that we'll look at a little bit more closely just a little bit later. The EAT screening tool and the EDI. If you score greater than a 30 or a 15 on those, then that means that's indicative or suggestive of an eating disorder. And so in sedentary females, we see about 10% will exceed this value and 8% for the EDI and EAT respectively here. For female exercisers, looking at the same 2 screening tools, the EAT and EDI, remember that the score greater than 30 and 15 is suggestive of an eating disorder. 22% will exceed this value and 20% for the EAT and EDI respectively. In sedentary males, this tends to be the lowest. However, more research is warranted with the use of these sorts of screening tools in athletes and taking a look at exercise participation as playing a role for the contribution of risk factors leading to disordered eating and eating disorders. What are the triggers for eating disorders in athletes? At the top of the list here we have prolonged periods of dieting or body mass fluctuations. So that's something that we want to be cognizant of with our athletes. Also, traumatic events, and this includes a whole slew of items here, perhaps not included on this list, but these are some of the major ones that we want to look out for. And an illness or an injury to that athlete or a family member could trigger an eating disorder. A new coach leaving home, especially for the very first time. Any kind of failure at school or at work. Familial problems, problems with relationships, whether it be friends or significant others, a death of a significant other, sexual abuse, or any kind of work transition. These are all known triggers for eating disorders in athletes. We also want to be cognizant of any kind of large increase in training volume and a significant associated body mass loss. That is certainly a sign that we want to be aware of. Also, the belief that menarche has begun too early is something that we want to look out for, particularly with coaches who have this mentality. We also want to take a look at early start of sport-specific training because that can also be indicative of risk for an eating disorder. Any kind of discrepancy between self-perceived and actual ideal body mass is something that we also want to be in tune with and the way that the athlete perceives themselves. And we also want to look at any kind of recommendation to lose body mass without any sort of guidance whatsoever. So if the athlete just suddenly says, I'm going to lose 5 pounds of fat, etc., and hasn't had that recommended from anyone, is certainly something that we want to be aware of and which raises a red flag for us. What are the warning signs of an eating disorder? Well, as far as anorexia nervosa goes, any kind of dramatic body mass loss certainly should raise a red flag. Any preoccupation with food, calories, and body mass beyond the usual. Everyone has a concern about calorie intake, etc., but if there's an unusual preoccupation with this sort of thing, then that's certainly something that we want to investigate a little bit further. Wearing baggy clothing or layered clothing, that's certainly another sign here. Relentless, excessive exercise beyond the training needs for a particular sport for that athlete. Extreme mood swings. Everyone, of course, is going to have some daily diurnal variation in how they feel, but if you see these really extreme mood swings, that's certainly a sign of an eating disorder. Also, avoiding food-related social activities is something that we want to consider here and pay attention to. As far as bulimia nervosa is concerned, any kind of noticeable body mass gain or loss is a sign, excessive concern about their body mass, bathroom visits after meals, and if you hear water running before, you hear the toilet flushing, that could be a sign that perhaps they're using the water to mask any emesis that's going on in the bathroom. Depressive moods, strict dieting followed by eating binges is also a red flag. Increased criticism of one's body. All are important signs that we want to take a note of and pay attention to with bulimia nervosa. What are the health consequences of an eating disorder? Well, the top of the list here is going to include macro and micronutrient deficiencies. This is always a concern anytime we're reducing the number of overall calories that we're consuming, because that means we're going to take in fewer nutrients. We also want to pay attention to dehydration, the extent of dehydration, and of course the subsequent electrolyte imbalances that may occur, especially hypokalemia, which is a low level of potassium in blood, because that can actually lead to cardiac arrhythmias, which could mean a myocardial infarction or heart attack, which could then eventually lead to death. We also want to pay attention to the blood acid-base balance and any kind of disturbances that we may have there. A lot of times these individuals are purging themselves, and so that self-induced vomiting is going to increase the amount of blood bicarbonate that we have. It makes the blood much more alkalinic, which then can lead to metabolic alkalosis, which is a health threat. As far as laxatives are concerned, the overuse of a laxative can actually decrease the amount of bicarbonate concentration in blood, which then can have the opposite problem here of metabolic acidosis. We can run into a situation where, since we're micronutrient deficient in, for example, iron. That could lead to microcytic hypochromic anemia. You could be deficient in folate, which would lead to megaloblastic anemia. So there are a lot of threats to red blood cells as far as micronutrient deficiencies are concerned. We can also run into a situation where we are chronically fatigued, or there may be an increased risk for infection or illnesses, an increased risk for musculoskeletal injuries. There's also an increased risk for overtraining syndrome, which is really difficult to describe and especially to treat. Overuse injuries are much more common. There could be a decrease in lean body mass, which then would lead to subsequent decreases in basal metabolic rate and resting metabolic rate. We can also run into some issues with cardiovascular disorders, so myocarditis and inflammation of the myocardium, simply from abusing an emetic called ipecac, which is very, very common as far as eating disorders are concerned, to try and vomit up and purge calories that way. Cardiomyopathy, so there may be something structurally with the myocardium that has been altered as a result of engaging in these unhealthy behaviors. We can also run into gastrointestinal disorders like ulcers. Dental caries are much more common because of the erosion of the enamel that occurs with the acid coming back up from the stomach and being in an area where there's no protection against that acid, like the teeth and the esophagus. We've got abdominal cramping that is more common, diarrhea, and hemorrhoids. Depression seems to be more common as well in eating disorders. And finally here is the female athlete triad, which we'll talk about in Module 19 here coming up, where we'll initiate a menstrual dysfunction because of the low availability of energy, which then predisposes that female athlete to osteopenia and possibly osteoporosis, so low bone mineral density. We also see an increase in cancer risk, especially esophageal cancer, because of the esophageal reflux from all the acid coming back up into the esophagus and eating away at the lining of the esophagus. The other interesting thing that can happen here is that in the very short term, we can get an increase in performance. And this is due to the upregulation of the hypothalamic pituitary adrenal axis, or the fight or flight response. We get an increase in the adrenal hormones, cortisol, epinephrine, and norepinephrine. Now, these are hormones that are breakdown hormones. They promote the release of substrates so that we can produce ATP. So you're going to have lipolysis and glycogenolysis occurring at a more accelerated rate, which then would give us more energy availability. Remember that this is very, very short-lived. This could potentially mask any sort of fatigue or chronic fatigue that the athlete has been experiencing, and may actually make the athlete feel pretty good and have this euphoric feeling. We may see an increase in the relative amount of VO2 max, and the athlete may actually feel lighter and may have some positive psychological benefit from this initial response. However, in the long term, it's highly probable that performance is going to decrease and be reduced. How do we prevent disordered eating in athletes? Well, this is not an easy task to accomplish because of the complexity. However, we know that if we can de-emphasize body mass and body composition, that could help. We also want to try and dispel any nutrition myths and correct that misinformation with the appropriate information. And this also involves, of course, educating the athlete, but as well as coaches and in some cases the families, because families can be very, very involved in an athlete's life. So it's important that we educate them as well. Most importantly here is we want to create this comfortable environment for athletes so that they can feel free to discuss their problems and concerns without having them feel like they're being judged. How can I screen a person for a potential eating disorder? Well, there are several screening tools available, and none of them are perfect or will give you 100% precision as far as identifying individuals who are at risk with or for an eating disorder. However, they are tools that we have in our tool bag here. So the first of which is the EAT, which is known as the Eating Attitudes Test. And there are several versions of this. One of them uses a 40-item test. The other one uses a 26-item test. And they both use a 6-point rating scale, which rates items from rarely to always. And in order to use this screening tool to indicate any sort of anorexia nervosa that might be present, you'd have to score a 30 or greater on the 40-item EAT and a 20 or greater on the 26-item EAT. The next tool that we have available is the EDI, or the Eating Disorder Inventory. This uses 64 items, and then there's an 8 subscale system, or 8 subcategory system. It looks at behaviors like body image and eating and dieting, as well as psychopathology. There is an updated version of this called the EDI-2, which increases the items to 91 and then uses an 11 subscale system, or 11 subcategories. However, the important point here to realize with most of these screening tools is that these aren't well validated in athletes, and so you may actually get false positives simply because of the types of questions that are asked on these surveys. And so just be aware of that. The next test here is the Bulimia Test Revise, or the Bullet R. This is a 28-item assessment and uses a 5-point scale rating system. Then there's the 3-factor eating questionnaire, or the TFEQ, which uses a 58-item questionnaire that looks at true, false, as well as multiple choice questions, and they have 3 subscales looking at these categories of restrained eating and tendency towards disinhibition, as well as perceived hunger. Steen and Bronnell in 1990 actually developed a questionnaire specifically for athletes, but in general, screening tools really haven't been tailored to the athletic population. So they're good tools to use and certainly useful. However, they are limited as far as their practical use. So we just need to keep in mind the limitations when we're using them with athletes. As far as intervention is concerned, the most important thing to remember is that the earlier that we can give an intervention, the better the prognosis is going to be if someone has disordered eating or an eating disorder. We, of course, want to incorporate the healthcare professional as part of the intervention process. As far as primary intervention, which means that we are intervening before an episode of disordered eating or an eating disorder actually occurs, that is very limited as far as the opportunities are concerned. So we have very little control over the contributing factors. So that triggering event more than likely will occur before we actually can intervene before the episodic event of an eating disorder or a disordered eating occurs. So our best next thing really is secondary intervention. So educating the athletes, educating the parents, the coaches, the training staffs, the physicians, the athletic administration, anybody who has an influence on the athlete needs to be educated about the risk factors for disordered eating and eating disorders. So this would include things about screening practices and healthy eating habits, as well as sound exercise practices. We also want to make sure that we are disseminating information about appropriate body fat and body composition. That's really important. Many people don't know what an appropriate level is. We also want to stress the value of early identification. So if everyone's well educated in identifying factors, then the likelihood of identifying somebody who is at risk increases, which means that we can intervene much earlier. And once we have identified an individual that's at risk, then any kind of prompt treatment is going to be aimed at minimizing the severity and duration of an eating disorder if it does in fact happen. So this is all a good thing. How are eating disorders treated? Well, first off, we got to identify the risk factors. That really is key, because a person may have an episode of an eating disorder, But we want to prevent the relapse and occurrence of a secondary episode. And so the only way we can do that is by trying to minimize the risk factors, and we need to identify them first before we can actually intervene. So we want to try to eliminate and reduce and or provide some sort of coping mechanism for the triggering event. So implementation of a screening program is pretty good idea here, and try and get pre-participation physical examination, educational meetings or workshops to try and identify any of these risk factors that may be present in the athletic population that we're dealing with. So we can use screening instruments like the EDI and EAT, as well as identify warning signs and symptoms, as we've discussed earlier. We also want to know what the community treatments have to offer. What are the community treatments that are available? So that's important because we can identify what steps need to be taken if we do think that somebody is susceptible to an eating disorder or is having an episode of an eating disorder. Okay. And also approach the athlete. Being able to approach the athlete in a sensitive and caring manner is really, really important. So we need to make sure that we can identify these individuals and then intervene with the best possible practice that is available in our community. Treatment for an eating disorder is definitely a multidisciplinary approach. Not one single person is going to be in control over all aspects of the treatment process. Of course, the physician should be involved so that we can get the medical status and allow for clearance of athletic participation, and also to coordinate overall care of that particular athlete. The registered dietitian or licensed dietitian can provide some nutritional guidance, which is important, and learning to modify eating behaviors, etc. A psychologist and a psychiatrist or a behavioral counselor. This is very, very important for the mental well-being, since these are disorders of mental state. It makes sense that these folks are going to be involved and intervene in helping these individuals overcome some of those triggering events. We also want to get the trainers and the coaches and the exercise physiologists all involved in this process, because they're going to be executing the training programs, and they're going to performance monitor these athletes. So they need to be cognizant of any sort of idiosyncrasies that may be present as a result of the eating disorder. And so they need to be well educated as well. Any young athletes that are still living at home, they need to have the family involved as well, because sometimes the family is the triggering event. As far as clinical treatment is concerned, it's important across the board with any individual, any healthcare practitioner, to establish good rapport and trust and understanding with the athlete. That is key, because there's only one way that you're going to get through the athlete, and that's to have their trust. And so it's important that we do that and build that early as possible. Any increase in dietary intake should be performed very slowly and very gradually. The worst thing that we want to do is to take the athlete to a buffet and have them ingest all these kilocalories. That's simply not an appropriate tactic to use in getting the athlete back to the body mass that they need to be at and replenish nutrient stores. We also want to encourage slow weight gain along those same lines, so we shouldn't make this the main focus. So we kind of want to make it be present there, but kind of in the background, so that it's not the main focus of the treatment. That could potentially compromise the entire treatment process. It's important to get a medical assessment. We want to look at blood pressure changes and heart rate measurements, as well as body temperature measurements. In the most severe cases, hospitalization is definitely going to be necessary for those individuals who have been assessed to have some dire medical emergencies. Of course, education is always key, so education of the athlete, education of the coach in the treatment process, very, very important here, making sure that we establish realistic goals. Realistic goals are very, very important. Grounding the athlete, grounding the coach in terms of the treatment process, so that we don't exaggerate any sort of goals that they may have in mind that are simply unrealistic. One of the nicest tools that we have available to us as healthcare practitioners is using examples of other individuals who, particularly athletes in this case, who have been very successful using what are considered healthy and best practice tactics at succeeding. And so we can show these examples and talk about the athletes and kinds of things that they're doing that may actually help in the treatment process. As far as the outcomes go, it's not good news. The outcomes are very highly variable. So anything from a full recovery to eventual death is expected with treatment of an eating disorder. You could have single, multiple episodes. It really doesn't matter. It's non-discriminatory as far as the outcome is concerned. So you may have been successful at overcoming it previously, but this episode, for whatever reason, the triggering factors and the psychological factors and the behavioral factors are all just not in sync and could lead to that person's demise. As far as the time frame goes, it could take weeks to years for recovery. Some folks never recover from this. So it's really kind of a sad eating disorder state to be in, and I really feel bad for these individuals. And so it's something that we need to have a tremendous amount of empathy for and be very, very sensitive to these individuals that are suffering from these problems. Some special notes here. If you have any diabetic athletes, type 1 diabetic athletes, you really want to pay close attention to how they are using their insulin, because if they are an athlete that is at risk for an eating disorder or disordered eating, they may actually skip or reduce their insulin dose so that they can force the release of glucose into the urine. So what they're actually doing is allowing themselves to become an uncontrolled type 1 diabetic, which does cause weight loss. However, dehydration is going to be a risk, as well as diabetic ketoacidosis. In one particular study, it was found that 86% of the women who were practicing this sort of tactic actually developed retinopathy within 4 years. So they had some pretty severe eye damage as a result of those high glucose concentrations in blood.